Hello, welcome to the 2020 Healthcare Leaders Summit hosted by Pennsylvania MGMA. I'm Tracy Evans. I'm the president of the board of directors, and on behalf of the board, I'm pleased to welcome you here to our first virtual event. I apologize for the technical difficulties, but I think we'll work through this and hopefully this is going to be really successful today. I want to thank all of our sponsors who have made the leap with us to this new platform. This year has been a trial for everyone, and those sponsors who have stood by us are most appreciated as steadfast partners to the Pennsylvania MGMA and all of our practices. I especially want to recognize the outstanding support of our platinum sponsor for our summit, Curtis Bay Medical Waste Services. They are the supporter of our first keynote today. Curtis Bay Medical Waste Services provides comprehensive medical waste solutions, including collection, transfer, transportation, recycling, waste reduction, sharps management, disposal, compliance training, and consulting services to healthcare providers. The company is dedicated to delivering customized professional responses to all medical waste disposal challenges. As an industry leader, Curtis Bay is focused on safety, compliance, and customer service. Please be sure to visit Curtis Bay and all of our sponsors and vendors in the virtual exhibit hall at some point over the next 2 days. The theme for our summit this year is the vision for healthcare. Practice leaders reimagine the future. When one of our board members recommended our first speaker today, he told us about his goals and presentation. We knew that he would be a perfect fit to kick off our conference. I'm pleased to introduce Nick Gaudiosi. Nick Gaudiosi grew up with a paraplegic mother stricken by multiple sclerosis, and then in his own life has battled with Lyme disease since age 30. He has seen the good, the bad, and the ugly side of healthcare. Nick speaks about healthcare passionately from a consumer perspective, but has a deep insider's knowledge of the way the system works. An advocate for change, he is inspired to help build a better health ecosystem for patients, doctors, and employers. Nick's career has spanned over 20 years in reinsurance, insurance, and healthcare technology. He started his career as a reinsurance broker with Towers Perrin, Forster, and Crosby, now a unit of Guy Carpenter Marsh. He spent the next 12 years as president and chief operating officer of a physician-owned malpractice insurance company, where he led the company through significant growth and expansion, followed by its sale to Medical Mutual, now Curry, in 2016. Nick spent the next 3 years integrating the companies and expanding nationally, leading to a period of significant growth and diversification into financial services. During this time, Nick served as COO of a subsidiary healthcare and insurance company and SVP of a billion-dollar holding company focused on strategy, business, and corporate development. Following the integration of the two companies, Nick joined the Safeguard Group as Senior Vice President overseeing healthcare strategy and group benefits. Please help me welcome Nick Gaudiosi.
Thank you for the introduction, Tracy. Thank you for reading through all that long bio. I'm going to try and keep things moving here and keep my fingers crossed that we don't experience any further technical glitches. Thank you to all the attendees who have joined. I'm going to take a moment here and try and share my screen, and then we'll get rolling. Okay, so everyone should be seeing a black and whatever that color is, a form of turquoise or blue, titled the Safeguard Group. So today, my goal is to take you through a theme that I hope dovetails with the theme of the conference quite well, consumerism trends that will reshape the future of healthcare delivery. Important to note, this is a COVID-19 edition. I've never done this presentation virtually, so I would ask for a bit of your empathy and understanding if there are glitches. I will do my best to stay on point. We do have a couple, I do want to run through a couple ground rules. You heard my background, so I don't want to read that out loud, but it is up here for your edification. But before, I want to give all of you who are attending a round of applause. I think that, you know, frontline workers have made a huge difference during this pandemic. I'm not certain that the administrative side of medicine has been lauded as much as the frontline clinical workers, but you know, I know, and I'm deeply thankful that all of you have kept these practices running during some really difficult times. Some of you may have experienced some financial difficulties, maybe even been furloughed or had some financial hardships at your practice. So again, our healthcare workers, you know, deserve a big round of applause. So if we were together, we would all be giving you a round of applause. So this is a virtual round of applause for all of you. One of the first ground rules is I'm here for you. I want you all to have a chance, you know, to win in this, what I call the new normal, or some are calling it the next normal, whichever you prefer to call it. So we do have a live chat feature, and our moderator, Erin, is assisting with that. So she will help get me questions real time. However, if I don't see your question real time, we will have Q&A at the end, and we will have various ways for you to get a hold of me if you have questions that you'd like me to answer. Second, I do have a broad array of topics to cover. The main goal here is really just to try and see into the future a little bit. So in order to see into the future, we're going to take a quick step back. We'll spend a lot of time talking about the current state, and then we'll focus on what trends may be reshaping the future of healthcare consumption. You will all get access to these slides. So for those of you who may be taking notes, we can save you the hassle. And third, I really want this to be fun. I want this to be exciting and interesting. My goal is not to put you to sleep. This is a very difficult environment to do this in. You're all behind screens. I'm not there with you in the audience, so we can't feel each other's energy level. But you know, I want to keep this thing moving and not get bogged down. So we'll start out by looking at you know, COVID and the impact it's had on the healthcare economy, potentially your business, and what the next normal might look like. So as patient volumes, you know, we hope start to pick up, we're looking for, you know, what is the way to survive, not just survive, but thrive in the new normal. So we'll look at the consumerism trends from the provider perspective, which is important to you, but I think equally as important from the consumer perspective, right? Understanding this new age consumer. We'll get a bit into understanding the, you know, the needs, the wants, the preferences that the new age healthcare consumer has. So to do so, we're going to look at provider demographic shifts. We're going to look at the growth of retail medicine. We're going to look at some vertical integration, which I'll explain exactly what that is. We're going to look at some of the site of service movements and shifts, and we'll take a look at practice patterns. So there's a lot to look at. We will touch briefly on private equity's role in healthcare, because if you are an independent practice, you probably at the board level, if you're part of those discussions, may have been entertaining you know, a proposal from one of many different suitors, one of whom may have been private equity. So we'll also pursue some answers to the questions, why is healthcare so expensive? I think that's a burning question that most healthcare consumers have. And then to close, we'll look at the patient of the future and how that affects medical practices in the changing role of health insurers. So during this you know, unprecedented pandemic, we call it a once in 100-year pandemic, we hope, what light can we find amidst the darkness? You know, that's sort of the answers that we want to find today. What opportunities can be envisioned for the U.S. health system as COVID cases reached in the United States 7 million with over 200,000 deaths? So we'll take a look at some of the effects that it's had on the healthcare economy itself and see if any silver linings in fact do exist. So healthcare companies, you know, they need to simultaneously, and you're in that category as a healthcare company. I call it, you'll hear me refer to you as the business of healthcare, healthcare practices, but you really, you know, it's important that you simultaneously monitor the consumer trends, adapt your business models appropriately, and then plan for business continuity in the event that we have another pandemic, which we hope we all hope we don't, of course, and then ensure that your employees are safe and healthy, all while managing the chaos and ambiguity of the crisis and delivering excellent patient care. It sounds like an impossible task, but I know that you've all done an exemplary job getting this far, and hopefully some of the content here will help you get over that next hump. So the healthcare economy, it was impacted probably more than any other sector of our U.S. economy. Historically, we talk about healthcare as being relatively immune from recessions. Well, that all changed, right? People get sick during good and bad times, and demand for medical care usually is relatively constant across any business cycle, across any geography. Health insurance also is there to reduce the out-of-pocket cost for people to consume care. Thus, when people get sick, at least those with health insurance, they can still afford to visit physicians, and that's what makes it generally recession-proof. Well, now we're operating under a new norm where people have been asked to curtail outside activities, particularly those who had medical conditions that put them at risk. So on top of the desire to keep medical offices, clear and reduce the risk of being a point of disease spread, insurance that privately insured patients have today is, as you all know and might be experiencing personally, less generous than it was during past recessions. All these trends have led to a significant contraction of the healthcare economy, and certainly you've probably seen in your practices a contraction of revenues. And so with cash tight, people, and uncertainty in the economy, people are postponing all kinds of care, from office visits to imaging procedures to filling prescriptions for medications. And in a moment, we'll take a look at the reduction and the major shift in supply and demand with elective procedures. So this was a look as of the end of March, just to sort of put it into context. The healthcare offices, healthcare businesses, medical offices, mostly this is a primary care map, but as the healthcare economy faltered, it exacerbated an already big problem, which is physician shortages across some areas of the country. So although there's not national data on this, some primary care practices reported reductions in the use of healthcare services of up to 70%. I talked to some practices in the specialty lines, reductions 80 to 90%. And most physician practices, that certainly those that I've worked with in my career, they don't have major cash reserves. So the salaries of clinical staff had to be frozen or reduced. And in some cases, staff was furloughed. So this is for the week ending March 21st. The second largest source of unemployment insurance claims in the United States was from the healthcare business. I think what we need to see from that is that the magnitude the healthcare businesses have on the economy. At nearly 20% of our GDP, healthcare is a huge, huge part of our economic landscape. And so only second to healthcare were restaurants and bars. Now, fortunately, we believe the worst is over, and I hope that you all are experiencing some revenue gains in your practice. I hope that patients are returning, but we all know that dangers still linger, and we need to discuss more about how to prepare for what's ahead. To further shed light on the exacerbation of this problem in our country, the physician shortage problem, this statistic always catches my attention. It takes, for first-time appointments, it takes an average of 24 days to schedule a first-time appointment with a physician. You all may be sitting there going, well, that's not true in my jurisdiction. This is in 15 major metropolitan cities, and Philadelphia is certainly one of them. And that's where I reside. So, that's just a wait time that patients are, find to be unacceptable. It frustrates them. And we'll talk about what patients do when they're faced with this situation. And what they do is typically leak out of the traditional medicine system into something that I call retail medicine, probably something that you all are familiar with. I don't know what your feelings on it are, but I'll share with you in a moment my feelings on retail medicine. We're talking about the Walgreens, the Walmarts, the Ready clinics, the fast medicine. So according to the survey, a national physician survey from Merritt Hawkins, the average wait time for new patients seeking an appointment with a dermatologist in major metropolitan areas was as high as 32 days. So you can see that there is a shortage. It is exacerbated in certain areas. It is exacerbated in certain specialties. Mental and behavioral health is certainly one of those specialties where the wait times can be much longer. So the point here is, COVID came at a time when the healthcare system was already strained, shortages already existed. And now we look at the map. 2 slides ago, we saw this same map as of March. This is the same map as of June. It basically is showing that an additional 1,000 counties across our country now have a shortage of first-line medical practices, mostly family and internal medicine practices, due to the closures and cutbacks. That's obviously not good for patient care. That's not good for practice revenue. It's really not good for anyone. So probably the most resounding thing that happened during this pandemic on the healthcare economy is how quickly it changed demand for healthcare services. Almost overnight, almost in an instant, it has disrupted the typical healthcare patterns and created a whole new supply and demand paradigm. So when the pandemic began, everyone had difficulty, obviously, with the supply of reliable PPE. It was a disrupted supply chain, and many of you might have experienced that the cost went up significantly. After March, when the pandemic started rolling out, it started affecting clinical staff. Probably, in your practices, when clinical staff started contracting the illness, that required entire health teams to shut down and quarantine. This led to significant business interruption losses. And that's the business that I'm in, the insurance and risk management business. And unfortunately, as you may have found, most of these losses that practices incurred were not covered by insurance. And many hospitals and provider groups weren't prepared for the surge in the use of telemedicine. Certainly, we'll talk in the next slide about how telemedicine has gone from what we call novelty to mainstream and how quickly that happened. But most practices either didn't have a tested and vetted platform for telemedicine, or they didn't have the infrastructure and staff, enough staff trained and in place to rapidly offer telehealth services. But some practices who were prepared benefited greatly with an uptick in their volume. So lastly, hospitals in the US lost between 30 and 55% of their elective patient volume during the first spike in COVID, which was obviously in March. Visits to physicians' offices and outpatient departments sank to similar levels, but by May we saw a brief uptick, and then a second spike in late June and July squashed any of that uptick in growth. So in a few slides, we'll talk about in the aggregate how many billions of dollars of losses this is causing to the hospital systems and to physician practices. I tend to focus more on physician practices. I don't typically work with large hospital systems. I tend to advocate for physician practices, independent physician practices, getting what they need through the CARES Act, through the grants, and bolstering their financial strength so that they can exist and don't become another casualty of this pandemic. So here we're shifting, we're just looking at telemedicine from novelty to mainstream. It was very frustrating. I was part of a telemedicine company board in 2012. As a younger guy, I thought, this is the greatest thing ever. This is going to change patient care. It's going to change consumer behavior. And obviously, as everyone is familiar, until health insurers and others and government payers started recognizing the effectiveness, the efficacy, they really didn't want to start covering or paying or reimbursing properly for telemedicine. So it remained this novelty thing that only few people really used. Well, obviously now that has all changed, right? The pandemic has necessitated an unprecedented level of innovation. So one of the prominent manifestations is telehealth, among other digital health advances, which we'll talk about. So before the coronavirus outbreak, only 1 in 10 consumers had tried telehealth, healthcare consumers. Now, experts are predicting that it will soar to more than 1 billion this year. And 89% of consumers surveyed recently report that they're satisfied or very satisfied with the experience. So the point is, regardless of where you were pre-pandemic, I believe that every practice must improve their digital innovation. You need to include, I believe, the ability to offer telehealth to an increasingly larger cohort of patients, and the execution of telehealth in your practice really needs to be frictionless. It really needs to create that great customer experience. And as we talk a little bit later in this presentation about the customer of the future, I think I'll have you understanding why consumers are looking for those consumer grade experiences that they find in other sectors of the economy, like retail and like banking. So COVID in the healthcare economy, I touched upon this, but I want to sort of point out this term that is new, which is medical distancing. So we're probably all sitting here nodding heads going, yeah, patients have definitely avoided medical care for fear that this healthcare setting presents excess risk that they may contract COVID. That's certainly a real thing. I think that it's going to taper off over time, but right now your practice needs to be encouraging patients to come back, encouraging them that it's a safe environment, encouraging them that you've taken all the measures possible to ensure that that doesn't happen. So as millions, I just want to talk a bit, in a macro, while this slide is up, and it's not so much about the medical distancing, but when the economic consequences of lost jobs, I just want to point out how this is going to have a sort of trickle down effect on the healthcare economy for quite some time longer. So what we have is a massive loss of jobs, right? We have a massive loss of income. And with that comes a significant loss of health insurance, employer-sponsored health insurance. And so what I believe is going to happen is these millions of Americans are going to flush through that system, millions of uninsured Americans flush through the system, who have lost their employer health insurance, and they may no longer be able to afford care. Right? So there's that on top of the fear of returning to the clinical setting. So what I ask you all is, what tactics will providers be using to build back the patient revenues and drive profitability? You need to be exploring things like expanding your market power. Do you raise prices? Do you push volume more? I've been advising practices to focus on the fixed variables that they can control. So, taking measures to swiftly reduce operating expenses, or reimagine how the practice can operate more efficiently and effectively. So one example, just before we leave this slide, of innovation in this area is urgent care clinics. They've established drive-through services, right? So now passengers can get there safely, quickly, and effectively to get COVID-19 testing without physically entering the facility. That may not be a practical solution for your physical practice, but I'm sure if you sit down and spend some time focusing on strategy, there are ways to think about expanding the revenues. So I told you a few moments ago that I was going to talk about, in the aggregate, hospitals, the losses. This number is staggering, but hospitals' COVID-19 losses could top $320 billion, according to the American Hospital Association. That report was issued on 6/31/20. So obviously, main reason for that is it stalled out the routine and elective care, some of which was low value, but a great deal, as you all know, being insiders in healthcare, was high value stuff, high value procedures, surgeries, and the like. The postponed care, it may never be delivered, right? I mean, what we have to figure out is it never going to be delivered because the problem resolved naturally? Did the patient learn to live with their condition, or learn to say, maybe I don't need that surgery, I'll put it off? Possibly they'll treat themselves with less invasive treatments, such as exercise or diet or physical therapy. And the next question is, how do we avoid reverting to the pre-COVID system with high levels of inefficiency and waste? And when I talk about why is healthcare so expensive, I will touch upon that inefficiency and waste. So this is going to really require hospitals and practices to spend a great deal of time, again, on strategy and planning. The status quo business model that may have worked in the past is not going to be sustainable in a post-COVID world. I thought I'd show you this just because it's staggering the amount of money that was delivered to these health systems to prop them up. At the same time, many of them are going to operate in the red. So, this is just a snapshot in the greater Philadelphia area. So those part of Mount Nittany and sort of out west in Pittsburgh area. I apologize, I didn't put any of the hospital systems in there, but I think this gives just a good idea of how much money was infused relative to the losses. And in the last slide, you saw that 320 billion was the aggregate number of losses projected, and that was only offset by $175 billion in CARES Act funding, right? So there's a massive hole in healthcare for it to recover. So one shining silver lining in here, or shining star amongst this group, was Temple Health. And obviously I'm in Philadelphia, so I pay close attention to these systems. But Temple recently posted an $88 million profit. What I found interesting about that was they generated $45 million in revenue from caring for COVID patients. And they reportedly provided over 85,000 telehealth visits from March to August alone. And they said that that comprised 50% of the system's overall patient volume. So again, going back to those who were prepared with good technology and infrastructure, really sort of reaped the rewards and the benefits of being able to flip the switch and deliver care to patients in an effective, efficient, safe manner. So here we're going to shift gears. I told you that we'll look at delivery trends. So from the provider's level, we'll talk really quickly about why is healthcare so expensive, and then we'll focus on the consumer of the future, which I hope leaves you with a bit better understanding of the millennials, the Gen Xers, what their consumer preferences will look like, and why they're not going to settle for the status quo that their parents settled for in healthcare. So we'll dive right into this section. We're going to look at some provider demographic shifts. I'm going to go rather quickly through this because this is certainly stuff and content that you know. I'm just hoping to present it in a bit of a different fashion. I will spend a little bit more time on private equity's role in healthcare. I've found through talking to practices, it's an area that they want to know more about. They want to understand, why private equity is interested in their business, what results have come from other practices maybe who have sold their practice to private equity. I'm certainly not necessarily an advocate of that model. I'm an advocate of fiercely independent practices remaining not just viable, but figuring out ways to thrive and aggregate amongst themselves. So a bit less exciting section, but we'll get through this and hopefully you find some of these things, some of these points interested. So just a snapshot in the aggregate, physicians, over 800,000 of them in the United States. They don't really look, act, or behave or respond to incentives the way they used to. You really are starting to see a shift in payments, the way that they're paid, models. Obviously, we'll talk about employed physicians versus independent physicians. It's all changing rapidly. The newly practicing physician is really interested more in hospital employment. Certainly, the younger physician coming out of school, what we hear most often is, I want the set hours, I want the predictability, I want some debt forgiveness, because one of the statistics you'll see is they owe $150,000 or more on average of student loan debt. And that's really hard to recover from. So a lot of the health systems will offer them jobs, steady pay, benefits, and certainly some debt forgiveness depending on how long they stay employed. And a strong majority of these newly trained physicians, 91%, would prefer to be employed in few seek independent private practice setting, according to Health Leaders Media. To me, that's discouraging. I'm an advocate of physicians getting out of school, figuring out how to get into networks, how to get into structures where they can thrive, they can be independent. I'm a big fan of GPOs and other organizations that help physicians with the things that they're not trained necessarily to do, so that they can excel at clinical care, and that all of the business medicine aspects can be done very effectively by a partner, through a partnership. So again, according, more provider demographics here, according to the Association of Medical College Physicians, 35 and younger are projected to work 13 fewer hours than earlier cohorts. And I think that the reason for that is, when you're a physician and you're in your own practice, you're going to work as long, as hard as it takes for that practice to survive and thrive. Certainly there's pressure in the employed model by health systems for physicians to work harder and see more patients. But again, I think that the entrepreneurial physicians, probably in the aggregate work more hours. And then we'll touch upon this, when we get to the private equity, but physicians over a certain age, there's a real financial incentive for them to sell the practice before waiting too long. And typically right now, there's some, depending on specialty, certainly not in primary care, but in some of these subspecialties like urology and dermatology, there are some really lucrative financial multiples being offered for practices right now. And a lot of the physicians, and you'll see this in an infographic in a moment, are suffering from burnout and low job satisfaction. So, faced with the situation of getting a major payday that they never dreamed of, and being able to sort of punch out or know what period of time they have left and have some predictability. It's a very attractive model. Private equity obviously knows that. That's why they're so aggressively pursuing a lot of these practices. And we talked about the physician shortage already, so I'll skip over that. So it is a hotly competitive market for physicians for recruiting. Nearly half, 45% of physicians in their final year of residency receive more than 100 recruiting offers, and 2/3 of them receive more than 50 offers. So, if you are a physician graduating, there is a lot of work out there for you. And it's another fact that I find fascinating is that there's a significant increase in the use of non-physician clinicians, as I call them, which is nurse practitioners, physician assistants, CRNAs. And the people I speak with say, I actually spoke with a woman the other day who has a daughter who is a primary care doctor and a daughter who is a physician assistant. And she said their worlds are completely different. The daughter who's a physician assistant, is making a lot of money, can kind of go anywhere she wants in the country, has a lot of freedom and flexibility, sort of really enjoying her work. The daughter who's a primary care doctor feels a little bit more restrained, pressure to go work for a health system. I find that fascinating. So merger medicine, we'll talk about who is aggregating the physician practices. Obviously, in addition to private equity, we're looking at payers, we're looking at MSOs, which is more of an independent physician model, and we're looking at national chains. We're looking at groups like Optum, and obviously hospitals have been in this game of aggregating physicians for some time. Optum Care, which is the division of Optum, the United Health Group Optum, that employs physicians. They employ over 55,000 physicians. So they are today, as we sit here, the largest aggregator of physicians and providers in the market today. When we do talk about vertical integration, we'll talk about why that works well for them when they own sites of service, they own primary care practices, and they try and keep everything nicely packaged and bundled within their, within their brand. So I promise you this infographic. This looks at two things, physician burnout on the left, and this looks at physician employment on the right. So physician burnout, believe it or not, has been deemed a public health crisis. It was a report from the Massachusetts Healthcare Organizations and Harvard Institutes, and it said that complicated computer interfaces and the growing burden of administrative tasks have pushed physician engagement with patients and exacerbated the problem. Pushed out physician engagement with patients, exacerbated the problem. And then a 2018 Merritt Hawkins survey found that 78% of physicians experience professional burnout. And one of the chief complaints being doctors' frustrations with inefficient EHR, in addition to the time that they had to spend on administrative tasks versus clinical care. So a lot of physicians, I believe, feel they're on a treadmill, they're on a conveyor belt. They're not afraid of the work. The ones I've talked to, they love the clinical aspects of their job. It's all the work that has nothing to do with patient care that makes physicians unhappy. And I think it makes patients unhappy too, because they feel the system is failing them, which we'll talk about a little bit more when we talk about consumer preferences. On the right is physician employment. I'm not going to spend too much time, but basically for the first time ever, less than half physicians practicing in the United States are independent or owners of their own practice. So we've been seeing those numbers decline for quite some time. From 2012 to 2015, the number of hospital employed physicians jumped by 49%, staggering amount. And from 2016 to 2018, we saw a little bit improvement. The increase was only 6%, but the recent headlines about the number of independent practices looking for a partner has shown a huge uptick. And what my fear is with the pandemic, with the revenue losses, the business interruption losses, a lot of independent practices are teetering on financial ruin and probably looking for some sort of white knight to save them. So again, are the cards stacked against them being physicians? Physicians, I really, I say I empathize with them. I really do, because they're caught in the middle of this inefficient system. They lack training for certain important areas. Certainly when it comes to clinical care or the care that younger consumers care about, more modernized care like nutrition and genomics. Those are not things that are part of the average primary care practice. And this is problematic because, you have sort of a culture clash. You have physicians who are struggling to figure out how to survive in this system. And you've got consumers whose preferences are so radically different than the previous generation. And what's going to happen is there's going to be some new market entrants that are going to solve those problems, while traditional medicine sort of looks further and further like it's fading into the background. At least that's my belief in the trends that I've sort of seen. But my point here is to point those out to you and sort of help you get over the hump of saying, how do we prepare the practice? How do we see those trends? How do we prepare ourselves so that we can thrive in that new normal? The other part of this is that, we'll talk more about employer-sponsored healthcare. And the only reason I want to talk about that is because it dovetails into what consumers are faced with. Most physician practices are not prepared to discuss a key component of value, which is cost or pricing. And a large majority of the healthcare leaders surveyed said they believe physicians are ill-equipped to discuss cost effectively. 86% lack the training they would need to discuss cost constraints affecting their patients. And by this, I mean their patients are having higher and higher deductibles. They're responsible for more of the out-of-pocket cost. And so they're behaving more like consumers of other goods and services. When they come to you, they want to say, well, what is that going to cost me? Because generally speaking, $2,000, $3,000, or $4,000 or $5,000 of the care is out of their own pocket. So we'll look at retail medicine here and the rise of consumerism. Retail medicine means the Walmarts, the CVS, the Walgreens, and the Best Buys, the companies that you typically think of as retailers entering into the healthcare space. So these are alternative care sites that are reportedly hitting the bottom line of community providers hard, especially in certain geographies, by taking away the lion's share of these minor acute visits. So you think your average pediatrics practice, you have these millennial patients. They say, well, you know what? I don't feel like calling and making an appointment anymore. I don't feel like waiting. It's inconvenient for me. I'm going to take my child to one of these locations that make it radically convenient for me to get seen. I, as a former malpractice executive, really feel like that's a little bit troubling because it leaves the community docs to deal with the harder cases, and they get paid less in relation to the amount of time it takes. So this is a trend that is picking up steam. Walmart, for example, opened 5 healthcare supercenters. Within those supercenters, you can get imaging done, you can get dentistry done, you can get all of your general internal medicine and well visits done. So it's the expansion of what we thought of as sort of the Ready Clinic or the Minute Clinic that CVS had. And CVS is following suit with what they call the health hubs, and they're planning 1,500 locations by 2021. So just imagine having these centers pop up, these big, well-funded retailers popping up in your neighborhood. And then imagine the new age consumer and the marketing dollars that they have to attract those people. It's scary for me to think about how the leakage out of the traditional medicine is going to affect practices. And it's not a doom and gloom scenario. I'm bringing these things up because, I think it's important to recognize these trends. So again, more on the vertical integration. We saw a few years ago, Aetna, one of the household names in health insurance, merge with CVS. It was a $69 billion merger of a health plan and a pharmacy chain. And so the point in vertical integration is it occurs at different levels of the healthcare supply chain. And the goal is to combine as many services as possible, such as when hospitals acquire physician practices, that's vertical integration, or when the health plan acquires the pharmacy benefit managers and physicians and sites of service. So generally speaking, vertical integration is thought to be bad for consumers. I don't think it's great for independent physician practices. It typically leads to price increases, and it's found to lower the levels of transparency. But it has been a major trend over the past few years, and the only thing really stopping the growth of this vertical integration is antitrust lawsuits. So except in the face of antitrust lawsuits, the deal flow is projected to remain very, very strong. So we talk about the shifting sites of service from hospitals to outpatient care. This has been going on probably for a decade or more. We know that providing care within the hospital walls costs more money. So there are lots of people out there trying to re-engineer care to direct more volume to community outpatient locations. Certainly, value-based contracting has accelerated this shift, and telehealth is going to accelerate the shift even more. We talked about its move from novelty to mainstream. COVID-19 brought telehealth, just into the forefront, accelerating it so much that in the past month, 3 telehealth companies filed for their initial public offering, creating a market value in the tens of billions of dollars. Lastly here, physicians control 87% of all personal spending on healthcare through hospital admissions. So the physicians are a really, really important part. They're an important target for those looking to control the patient, right? An important part because they really control the spending through test orders, admissions, prescriptions, procedures. So the payment patterns are shifting too. Obviously, you're all familiar with MACRA and MIPS. That fee for service was always criticized and characterized by over-treatment, overprescribed medication, and over-testing. Whether that was true or not, that was the name that it got. That was the reason or the catalyst for shifting to a value-based care model, which was initiated back in the ACA. And encourages coordinated team approaches to patient care and rewards efficiency and quality. A lot of that for most of you may have been like a unicorn. You're trying to figure out, what does it actually look like? How do we actually aggregate our data? How do we report our data? I think a lot of groups have made great strides in that area. Some are still struggling with that. But the time frame has been extended and extended again. And now we're looking at, 2021, I believe still 2021 for payments in the QPP programs. What's at stake, up or down by 7%. These are significant changes to revenue if you're not on top of figuring out whether you went into one of these APMs or whether you're trying to master MIPS. That's all I'll discuss about that. That can be a totally separate conversation and presentation in and of itself. The last note here really affects emergency medicine providers, I think the most. But it's interesting that in April, during the chaos and calamity of the pandemic, something that was under a lot of scrutiny, which is this surprise billing, sort of got snuck into some of the funding and the CARES grants that were provided to the healthcare providers. So on April 20th, the requirement by the Trump administration for providers to certify as a condition for supplemental COVID-19 relief was that they would not seek to collect out-of-pocket expenses from out-of-network patients. And so those of you who are in the emergency medicine practice, you're probably very familiar with this. It's been a major source of contention with both consumers, insurers, and practitioners. So I talked about the fact that we've seen the ratio of non-physician to physician clinicians continue to decrease. We've seen the rise in concierge medicine. Certainly direct primary care is something I could talk an entire presentation on. I'm a big believer in direct primary care. It removes a lot of the third-party surrogates. It removes a lot of the bureaucracy, simplified payment models, removes complexity and waste. A lot of physicians are leaving sort of mainstream traditional practices to go this route. And again, primary care physicians, such as family physicians, top the list of most in-demand doctors, in part because their role as the quarterbacks of care. And you saw moments ago how much control they have over admissions and other things that drive revenue. So I'm going to skip over this slide because we're getting kind of deep. We talked about the regulations and integration. So we talked about the shift briefly from value-based care. That's not what this is about. You all know those things. You all heard me talk about physician aggregation, the regulatory issues. So I can skip over that slide. You're all getting these slides, so you can take some more time to dive into those slides after the fact. But for the purpose here, I really want to get into the last half of this presentation here. So we know that economic integration of physician practices is going on. There's clinical integration going on as well. Certainly you have clinically integrated networks. You have IPAs, you have MSOs, ACOs, all different forms of alphabet soup out there that are trying to aggregate physicians. What pathway you choose depends on your strategic plan, what's best for your practice. But certainly, I would expect that you're sitting at board level discussions, figuring out which one of these is right for you. And I think that most practices by now have figured that out. This is just to add a little levity. What will the next normal look like after value-based care is fully implemented and then the COVID losses flush their way through? For a lot of groups, it may look like this picture, right? Private equity companies are salivating because they know that revenues and profits are going to take a significant hit for a lot of practices, and they'll come in and do what they do. And we'll talk a bit about that. So private equity's role in healthcare has been growing. Relative to the overall healthcare picture, it's still very small. But McKinsey estimates that there's about $1.8 billion of what they call in financial terms an investment banking terms, they call it dry powder in the private equity space. And so healthcare is obviously growing faster than the GDP, and it's essentially was recession proof. We found out during the pandemic that that may not be true. And most independent practices are not, and I say this in quotes, professionally managed. That's not my words. Those are the words of third parties, citing reasons why PE looks at opportunities to roll up these not professionally managed practices. And so groups still remain fragmented, and they look at the opportunity to create the operational excellence and efficiencies. I think that's typical of any industry that private equity is going to come into. They look to lower operating expenses, grow revenues, take out the inefficiencies. It's no different in medicine. So large health system deals are putting pressure on the patient referral patterns, and independents need to stay in business. So big insurers are also exerting the same pressures. So PE has been a very attractive model for some groups that I've dealt with. I know I'm familiar with some in the dermatology space, the OB space. They come with, you have to go into it with your eyes wide open. There's certainly, I do a separate presentation on private equity's role in healthcare. We look at deal structures. We look at nuances of what kind of efficiencies it creates, and certainly what the physicians give up in return, because it is not a fair trade, in my opinion. There is a lot that the physicians will be giving up and sacrificing in order to go this direction. Most common targets have been historically anesthesia at 20% of all PE deals, multi-specialty around 20%, ER 12%, family medicine 11%, and dermatology around 10%. So these deals, they're based on multiples of EBITDA, which is a measure of operating performance. The younger physicians who have more years to practice typically find these deals unattractive, and the valuations for what we call platform companies, which is the first deal, that typically the largest group that a PE will go after, those valuations are richer. And then what they call the after effect is the tuck in. So a practice that may be tucked in later, they get a less attractive multiple. And that's generally the way it works. If you want to find out more about this stuff, I'm more than happy to talk to you offline. I have a lot more information to share with you there. But so again, another little pivot point here. Why is healthcare so expensive? So let's just take a look really quick in the macro. We've got chronic illness. We have undervalued primary care. We have the rise of pharmaceutical drugs. We have a bloated administrative layer of cost. We have what I refer to as a Byzantine payment system, and I'll talk briefly about why that is. We have some obviously some monopolistic behaviors. I don't think anybody would argue with that from both health plans and insurers. And then you have the constant churning of the merger medicine. If we look at chronic disease, it's the #1 contributing factor to the overspending in the U.S. healthcare system. 90% of our $3.3 trillion is for people with chronic and mental health conditions. So chronic disease is, in fact, the tapeworm in the American economy, and certainly in the healthcare economy. If we look at this, the average length of a primary care doctor visit is 15 minutes. I think we all know that. And I say average. I'm sure that some of you have figured out ways to make those visits longer, more qualitative. But this generally results in patients receiving a prescription drug order 76% of the time, which is pretty staggering and pretty disturbing. On the surface, this primary care strategy seems driven mostly by insurance reimbursement models. And I think everybody would agree that, if there was a reimbursement model to allow primary care doctors to spend more time with patients and to think and link and to really learn their lifestyle and their behavior, sort of the Norman Rockwell era of doctor that we remember seeing, I think certainly doctors would be all in on that model. But we don't live in that reality. Most patients seeking a doctor are not cash pay. They're coming there with the insurance. And the average load for a primary care doctor is 2,300 patients. So, that's pretty staggering. These numbers will continue to be stressed as the aging population increased chronic diseases will use a greater volume of healthcare services. There's really no way about it. You have a shortage of physicians in primary care. You have an aging population. Again, I talk about the clash. It's bound to sort of create a friction at some point. You've heard me say it before, primary care is undervalued. I believe that fundamentally in the work that I've done. It doesn't work nearly the way it did in the 60s, 70s, or 80s, that Norman Rockwell era, certainly. If healthcare is nearly 20% of our GDP or 3.5 trillion, we're only spending 4 to 6% overall. This is according to a JAMA study. on primary care. It just doesn't make sense, in my opinion. Specialty care, hospitals and specialists are leading the spending. But as we'll see in a few slides, physician pay still remains a very small portion of total healthcare spending. And I know physician pay comes under scrutiny sometimes. Sometimes consumers get confused, high income earners, oh, it's the physicians, healthcare is so expensive because physicians get paid so much. Actually, that's not true. So an estimated 105,000 primary care doctors are going to be needed by 2030 to meet this demand. So this is a major public health crisis in the making. And I could get into a lot of the reasons as to why, but that's for, again, a separate topic, separate conversation. I think this picture is worth 1,000 words. If primary care wasn't broken, it wouldn't be potentially leading to increased chronic disease, increased prescription drug use, increased physician burnout, and increased patient dissatisfaction. These are all tragic consequences of a system that needs change. When we just take a look at prescription drugs filled by Americans, both adults and children, it increased by 85% over 20 years, while the US population's only increased 20% over the same period of time. So something is wrong here. We certainly have a pain crisis in our country. We know that approximately 80% of the global supply of opioids is consumed in the United States. I don't think that shocks anyone given the struggles we've had with opioid deaths, the opioid crisis. 300 million pain prescriptions equal a $24 billion market value. So obviously there's perverse incentive here. Fortunately, the administration currently is taking aim at this and trying to, through lawsuits and other criminal prosecutions, take aim at those who were over flooding the market with these drugs. But there were over 20,000 fentanyl deaths in 2016 in the United States, which is just sad. So again, physician pay versus national health expenditures. You may not be able to see this really well, but physicians are they're paid 7.3% of our national health expenditure, right? And so the goal of medical care is clinical care. And so in order to improve it, we need to reduce the administrative bloat and that layer in red there that has nothing to do with the quality of care. And so if healthcare is going to spend less, you look at these inputs, the inputs need to cost less. So number one input that needs to cost less is reducing the administrative costs of healthcare. And, administrative costs come from hospitals, health systems, insurers. We all know who they are. But I thought the most important part on here was that physicians' pay, nurses' pay represents such a small portion of our overall spending. I talked earlier about Byzantine payment systems. So basically our payment system in this country is so overcomplicated. It's confusing. Some would argue it's unethical. It's opaque. It's convoluted. Consumer Reports in May 2018 said a growing number of medical services from MRI to blood work to outpatient surgery could cost you less, sometimes a lot less, if you pay the provider out of your own pocket and leave your insurer out of the picture. I think more and more consumers are realizing that. And a much smaller percentage today of care is direct pay when you compare it to 1980s, which is what this chart actually does. So that's changing with trends like direct primary care. It's changing with the way employers are sponsoring care for their employees. But we look at last week, a company called Hims and Hers. I found it fascinating, a $2 billion initial public offering. It was the first all cash pay primary care telemedicine model to reach scale. And so I think that's a sign of what's happening in consumer trends. And this is the slide that gets people's attention a lot, but shocking reality is that healthcare costs are flat. Well, I don't understand. What do you mean they're flat? Well, it's really the insurance premiums and that drive cost up, right? So cash pay and self-pay prices, there was a study done, there's a book written on this actually, Catastrophic Care by David Goldhill. And he looks at cash pay prices for many physician visits, diagnostic studies, and treatments around the country, and they have remained flat for quite some time. And physicians' pay, as we talked about, is only 27 cents of every dollar. And so what is increasingly expensive about healthcare is price gouging. And I'm not saying every hospital does this, but we've all seen examples of it. Price increases by insurers. And I'll point out that I don't think it's right that 3 of the largest health insurers in our country made record profits in the past year during a pandemic when Americans were suffering. But that's the perverse incentive that drives up cost. We could talk all day long about pharmacy benefit managers, the games they play, and then we talked about the administrative bloat. And then you have your billions of dollars every year of criminal fraud that involves inappropriate treatment or schemes and scams. So what is the role of the health plan? How's it changing? Health plans, in my opinion, are going to move beyond just processing claims, and they need to focus on the well-being of their members. Even Deloitte Consulting released a report on the health plan of the future, and they said we expect them to become data conveners. We expect them to be science and insight engines, and a platform for as infrastructure builders. I think that, my take is that for years, insurers had a very simple business, health insurers had a very simple business model. They contract with the providers and they bring them in network, they process claims, and they're, in what appears to be the risk business. But the fact of the matter is they always had buffers to maintain pretty healthy profit margins. Interestingly, last bullet on there, I've been predicting for some time that one of the tech giants would enter the health insurance space because they know how to use the data to their advantage. And certainly that came true. On August 25th, Google's parent company Alphabet has a subsidiary company called Verily, and they announced that they are entering the health insurance business with a company called Coefficient. They will enter the stop loss business. Walmart has entered the insurance business. This was a press release yesterday, October 6th. They want to be the trusted partner in your healthcare journey. So I think we are running, Erin, I just want to do a time check. I know we're.
It is 10:06. We should be, heading on to Q&A in the next.
Okay.
Yeah.
So let's wrap up. I have, this section, I just want to talk about real quickly and then wrap up, which is the patient of the future, because I think that's important. So key concepts that will redefine healthcare. McKinsey said that they believe that 3 priorities will define the customer experience in the post-pandemic era, which is digital excellence, safe and contactless engagement, and dynamic customer insights. So I've ordered 9 things that I think will reshape and redefine healthcare. And I'm not going to go through them in detail, but it's consumerism and patient centricity, a move to a digital first interaction, which is telemedicine and other digital means, personalization of care versus standardization. The healthcare framework has been built on standardization, precision medicine and artificial intelligence, genomics, genetic testing and gene therapy treatments, this concept of radical convenience and pricing transparency, and the shifting consumer demands of the millennials and the Gen Z generation, data transparency, portability, interoperability. And then you'll see with the younger consumer, there's a strong interest in wellness and alternative medicine. And I think that traditional medicine providers need to figure out how to cater to those needs. Otherwise, I think that those consumers might vote with their feet and go to more, non-traditional means of consuming healthcare. I'm going to stop there. You will have access to all of these slides that talk about the shift from the doc's office to retail clinic. We did cover a lot of information. I covered most of what I wanted to cover. So let's pause there and open it up.
Thank you, Nick. So we have one question already in the chat. I would encourage others to type some questions in either to the Q&A box or to the chat room on the right-hand side of your screen. Our first question is from Angie. She asked if the CARES Act was the funding that has come through in August. I think it was a little bit earlier than that. But if so, she wanted to know, a lot of the physician practices did not get approved for some of the funding, at least in Western Pennsylvania. And she wanted to ask your opinion on why you think some of the smaller physician practices did not get approved for funding.
Right. Okay. So that was one of the fears that I had when I saw. I have a few slides that I can share offline that specifically highlight what CARES Act was passed and what portion of that CARES Act had funding that was directed to healthcare. Naturally, as these things tend to happen, the biggest entities, have the biggest hands out and get the money first. And I think it should have been actually reversed, right? I mean, obviously we needed to prop up the health systems and the hospitals. We couldn't have them fail. But my biggest fear watching all of that and seeing how the funds were being distributed was that the smaller practices were not going to get the money that they needed to thrive. So in lieu of that, a lot of the smaller practices filed for the PPP loans. I talked to a lot of them that did get that money. But as it relates to actual CARES, the billions and billions of dollars that were apportioned to healthcare through CARES. Some of that money was carved out through prepayment on Medicare dollars. There were various different ways that the practice could get the dollars. I'm not familiar with how each practice went about it, but I do know that some did receive a portion of that CARES funding. Some received it through the PPP, and others sort of through a hybrid model. I would encourage all the practices who didn't receive what they needed to go back and revisit that, talk to whoever they were working with, whether it was an accountant or other paid professional. I do know that there is some talk about in the next round of stimulus funding, there being more dollars apportioned to primary care, to the smaller independent medical practices. So, but I have no idea when that will be. Obviously, yesterday the market reacted to some news that those talks, which would encompass, I think, more funding for healthcare, have been put on hold until the election is over, unfortunately.
Are there other questions for Nick? Do you see an impact from, can you predict, do you have your crystal ball ready for what the, how do you see the election impacting any immediate impact on healthcare trends for 2021?
I forgot to read in one of my disclaimers that I said I would not get into politics at all and really comment politically, but I'll answer that question. I don't see the election doing much to change sort of the path that you are all on as medical practices. What I do think the election will do is affect the markets more, and affect the big healthcare publicly traded stocks. So, if in a Biden situation, you're probably going to see the depreciation of large healthcare stocks like United Health Group and the big bucas, because you're going to see a fear that we're going to move more towards, less private insurance, more socialized medicine. I firmly believe, though, that no matter how the election goes, it's really there's not going to be a transformational change. I think whatever changes happen will only be incremental. I don't think that, even I was even sort of dissatisfied with the last debate because I felt like on both sides, there really wasn't an accurate portrayal of the actual healthcare debate, right? And the ACA and the repeal of the ACA and pre-existing conditions. I actually don't think a whole lot is going to change one way or another. There's going to be some uncertainty in the markets, and that's about it. And there will be, if in a Trump administration, another Trump administration, there probably will be a continuation of a focus on some of these pricing transparency things, some more competitiveness, allowing more open markets, free markets, competing across state lines. Certainly association health plans when it comes to the employer-sponsored care side. Association health plans are a good thing for physician practices. They're smaller. They need to figure out ways to aggregate to buy more affordable healthcare. So those are the small nuances, incremental things that I think will change. But I wouldn't have any sort of fear or anxiety over it one way or another.
Thank you. Well, I want to thank you. Not seeing any other questions. Thank you very much, Nick, and thank you all for joining us.
Thank you.